So, officially, good evening and a very warm welcome. And if anyone remembers what were those three focus areas that we discussed in the first class on the medication safety challenge, the three focus areas from WHO. Today we are discussing the third focus area. Anyone remembers what were the last two focus areas? You can put in the chat box also if you remember. Just a quick test of your memory if you are coming here regularly. Yes? Can we get some answers in the chat box? None? I can only see good evening. Yes, friends. Well, let me just remind you the first week we talked about the medication safety challenge as outlined by WHO. There were three focus areas. One was the high alert situations, the second was transitions of care, and the third one is polypharmacy. Now, many of us might not have focused much on polypharmacy. Uh, I know that in our training, we were not focusing on polypharmacy, but we might have learned about this in different contexts. So, we are going to today discuss about what WHO technical review talks about on polypharmacy. How do we ensure medication safety in polypharmacy? So, just give me a second. Let me just pull up the presentation. All right. Signia is in pursuit of patient safety, and this was our tagline for the last 2 years. And every year we do something specific for nurses and nurses to improve their understanding of this domain, patient safety. And I'm very convinced that whatsoever we do, and any number of people that we address, it will still be less to ensure patient safety in our organizations. I totally believe that that is what will happen. So we are grateful that the people who are returning to session every time and trying to educate themselves or maybe refresh their memory about how to ensure medication safety in various phases. You will have to give me just 1 second. There seems to be two black lines there, so I'm just trying to get that up. Something is, unfortunately, I have to stop the Facebook live stream because something is not working right. I don't want to waste your time. So let's get into the topic. And those who are not able to attend, you can always catch up all the videos on our YouTube channel. You will find all the previous three, video recordings you'll be able to find there. So as I told you, today's discussion is about medication safety in polypharmacy. Now, that's a very interesting topic. And as I read through the technical report, yes, many things that we knew in a different context. So, what are we going to discuss today? We'll talk about the prevalence of polypharmacy. We will talk about the factors influencing the polypharmacy, medication related harm in polypharmacy, medication review on polypharmacy, and implementing polypharmacy, and then health system approach to polypharmacy, and then role of nurses. As usual, we will end up by discussing what can nurses do in polypharmacy. So first and foremost, we need to understand what is polypharmacy. To now, just to illustrate that, I'm going to show a video on the YouTube. Let's take you to the YouTube now. Okay, just coming up.
Polypharmacy is defined as a prescription, administration, or the use of more than 5 medications at the same time. Approximately one third of elderly patients take more than 5 drugs. Not surprising, since more than 80% of elderly patients have more than 3 chronic conditions. Furthermore, conservative estimate is that at least 25 to 50% of older patients have drug side effects. 25% of these adverse drug reactions are preventable. The concern with polypharmacy stems from the increased risk of developing ADRs, which cause unnecessary hospital admissions, increasing healthcare costs, and most importantly, reducing the patient's quality of life. The risk factors for polypharmacy in the elderly are numerous and include poor communication from the doctors, cognition issues, deafness and poor eyesight, use of numerous over-the-counter medications, and presence of multiple prescribers. Further, because there is a paucity of pharmacokinetic and pharmacodynamic dynamic data from drug trials in the elderly, it is often difficult to foresee drug-to-drug interactions and subsequent ADRs. Physiological changes in old age also play a key role. In particular, the reduction of body water content, along with the concurrent increase in fat content, alters the distribution and accumulation of drugs in the system. Further, alterations in the gastrointestinal absorption, hepatic metabolism, and renal excretion all serve to alter the way drugs behave in the body as well as how the body responds to their effects. The way forward is to use every opportunity to review the patient's medication profile, maintain heightened vigilance for new symptoms, possibly caused by medications, and reduce unnecessary drugs known as de-prescribing. What is appropriate at one time can become inappropriate at a later time, as in the instance of warfarin and its association with falls. De-prescribing is a happiness pill for the doctor and the patient. Swallow it with pride.
So, friends, that is just setting the context and many of the things that was discussed in the YouTube video that you will be hearing those words again. This is slightly older video recording. It's 2016. So in the current document, the 5 medications have now been increased to 10 medications. Patients who are taking more than 10 medications is actually polypharmacy. That's the reason is all the medications, including the OTC, any supplements, any herbs, everything needs to be considered into that list. So, and this is a set of abbreviations from the same document. And I just found two new terms here. One is NNH, number needed to harm, and number needed to treat. This is, in the elderly population, what is the number of medication needed to treat that particular individual, and what number can harm. So this is supposed to be in the mind of the doctors all the time. So let's try to understand these definitions now. Polypharmacy, as the word says, poly and pharmacy is the concurrent use of multiple medications. So though there is no standard definition, so very often, as you saw in the video, it is more than use of 5 medication, and that includes everything: OTC, prescription, traditional, complementary medicines. So altogether, now they talk about 10 medications. So this is the usually accepted, norm about polypharmacy. Now the goal for polypharmacy, how do you maintain medication safety? The goal is actually to prevent any irrational prescription of medication, too many medication. I'm very sure that many of us, we go to the doctor, and then many times, doctors will write a set of medications for one particular condition. Some in the elderly, such prescription without care can lead to harm, because all the reasons you saw in the video, because of their body structure, their functions, one need to be very, very careful because they're already at high risk. Now, one quick reminder for all the nurses is also that we identify all patients above 65 as vulnerable. So many times, when I talk to nurses, the vulnerability is usually thought of as the risk to fall. Now, the vulnerability is in all forms, the vulnerability is there because the patient can get hospital acquired infection. They are at higher risk to catch infection. They are at higher risk for all kinds of harm, including medication harm, and they are at risk of developing fall. They are at risk of developing pressure ulcer. So, from all aspects, this group of patients are at risk of any kind of harm that can come. So today we are discussing about the safety in polypharmacy, because we know that when these patients get admitted, almost all of them will have many medicines that they are taking. So irrational prescription should be avoided, and the rational prescription of what is required to treat the patient. So we will be discussing what the various aspects of polypharmacy and how can safety be derived, and finally a word on how nurses, as nursing department or as nurses, can we make some difference. So therefore, appropriate polypharmacy should be considered at every point of initiation of a new treatment. Now, this is a very, very important statement that whenever you are going to see a doctor, I mean, many of you might be having elderly parents, and you might be taking your grandparents to the doctor. So this is something that you can keep in mind even as an individual, that whenever you go to the doctor, we talked about taking the entire prescription in the earlier episodes also, and here it is even more important that you take the prescription and make sure the doctor is able to think through that whether something needs to be added or not. I do manage polypharmacy of my mother, and that's a very good experience for me. And I have done that for my father earlier. That every prescription, I have to keep on reminding the doctor that we changed this medication last time, and now these are the results. And because I am from a healthcare background, I am able to highlight this is the liver function report that has come. It has not changed. The renal function remains same. So discussions are initiated on my, sharing, but that may not be the case in most of the patients. So we do expect nurses who are looking after elderly patients to be their safety champions, right? Now, all these sessions will help us to become an advocate for our patients at the bedside. When well, we say no, the what the mind does not know, the eyes cannot see. Obviously, we are trying to tell our minds what else we can know about polypharmacy today. So there are two terminologies: appropriate polypharmacy and inappropriate for polypharmacy. And I'm very sure by now, after you have seen the video, that you are kind of aware what is appropriate, what is not appropriate. There are four aspects to it. Appropriate polypharmacy is when the medicines that are prescribed to the elderly citizen is very specific to the therapeutic objectives, nothing more, nothing less. And ensuring that the medicine is going to benefit the person. That means the doctor should know there's a reasonable chance that this medicine will work. I'll give you a very recent practical example. Okay. So recently, my son, who is 23, me, I'm 63, and my mother is 84. All of us had COVID at the same time. So we consulted the doctor. So the doctor prescribed for my son azithromycin. Okay, I'm just talking about that one particular. And to me, he prescribed antiviral. And for my mother, it was just augmentin. So three different types of medicines. And when you think about it, it was all decided by the doctor based on the factors, the age factor. If you only look at the age factor, if you look at age factor, my son is young, so he should be strong enough to withstand. So he was given the regular, azithromycin. And for me, because he said, ma'am, you are 60 plus, so maybe it is better to be on the safer side, you take the antiviral. So that has proven to be more safer. So I took that medicine. And for my mother, the decision was taken that if she is already on so many medications, so let's not give her again antiviral, which is like pretty strong. So doctor said augmentin should do the work. So augmentin was given. So there was some thought process based on understanding the patient's age and other comorbidities. Some decisions were taken that this medicine is okay for this condition for this person. So that was what was being, thought over by the doctor. Then the medication therapy needs to be optimized to reduce the risk of any adverse reaction. So when the augmentin was given, the doctor double checked, is she on any, proton pump inhibitor or not, just to make sure. And he said that it should be only given during that period of treatment. So, and the last but not the least is very important that the patient is motivated and able to take all medicines. Can I ask everyone to mute yourself, please? Thank you. So the patient should be motivated and patient should be willing to take medicine. So once in a while we do this mistake, no, that we go to the doctor and we talk, speak for them and say this is what it is. The doctor will give a battery of medications without checking whether your mother, father, grandfather, grandmother is going to take the medication or not. It's the same thought process that needs to go in when every patient is going to the doctor. So inappropriate polypharmacy is just the opposite. You know, that most important thing is to think that one or the combination of several medicine causes ADR. Now, this is for the doctor to decide to do a medication review. I hope all of you remember last week we talked about medication. Last week we talked about medication reconciliation and medication review. So medication review becomes even more critical in this category of patients because they medication reviews not about asking what are all the medicines patient is getting. No, paying attention to the medicines that is there in the list and looking at any interactions that could be happening between drug food, drug herbal, drug supplements, so all that things a doctor needs to pay attention. So, this is what is appropriate and inappropriate polypharmacy, and this can happen anytime with anyone. Now, who is at risk? I'm very sure by now you are aware who all are at risk. So, the document talks about anyone who is over 65 years of age, and they have found that people who are living in care homes at a higher risk. But when you look at India, I would like to highlight all those senior citizens who are staying alone. Many of the parents are left alone in India and their children are in Australia, America, etc. So they are in their own home, not in a care home, but even they are at higher risk because you all the declining factors of age related declining factors are there in all the elderly people. So when they are, in this category, their risk for drug-drug interaction, higher risk of fall, ADRs, cognitive impairment, non-adherence, and poor nutritional status. We also saw in the video that it can be also to poor hydration status. I know for sure that when my mother does not take enough liquid, enough fluids throughout the day, she'll start looking more older as though she's sick. Immediately I will ask her, have you taken this at least 2 flasks of water yesterday? Then she will tell me, no, I have not taken enough. So this basic things becomes very important. And though I am telling my own experience with my mother, but it's the same with our patients. When we are looking after patients, do we pay attention to their hydration and nutrition status? Or are we those nurses who are waiting for a doctor's order to say, let the doctor write intake output, then I am going to pay attention? I think it's very, very important. That's where, we can pride ourselves saying that we give holistic nursing care and we do smart nursing care plans. So it is a complete, assessment of the patient and trying to understand at what risk each of my patient is. And I'm very sure in our hospitals we have a larger percentage of patients who are, like vulnerable category, elderly patients with comorbidities, we know that. So this is very important that we keep few things, and keeping eye on their nutritional status and their hydration status is the beginning. That's what I would say, that all of us, we should not overlook this factor, and this has got implications on every single patient, on their healing, on their recovery, how soon they go from hospital. So even for drug adverse reaction, you saw in the first video that why the hydration and nutrition is important, and it will be impaired because of their age factor, so we need to pay extra attention. So now multimorbidity is defined as the presence of two or more long-term health conditions, which we know that this can be defined as physical or mental health conditions such as diabetes and schizophrenia. So this is to understand when we talk about comorbidities or multimorbidities, ongoing conditions such as learning disability. So that means there are other, apart from the diagnosis, there are other morbidities which is stopping them from being in their full potential. Symptom complexes like they are very frail and they have chronic pain. Sensory impairment such as sight and hearing loss, alcohol and substance misuse. So all these together, so it's like a complete history, right? We all have been trained how to take patients history. So when we take history, are we look at these pieces of information as independent information, or are we marrying them to each other to say, oh, he's already 72, but he still continues to smoke, he's still drinking? Do we take those history? Can you hear well? Can you see well? Do we do all that? I sometimes keep asking these questions, do we do justice to the role that we have been given? So this is an answer that I would like you to answer to yourself. I am not going to answer for that. Understand the impact, the economic impact. Mismanaged polypharmacy contributed to 4% of the world's total avoidable cost due to suboptimal medicine use. So this is the data from the same technical report. A total of US 18 billion, that is 0.3% of the global total health expenditure, could be avoided if we manage this polypharmacy segment. So that's a lot of money that we are losing because we are not managing polypharmacy the way it is required to be done. So what are the specific recommendation? Investment in medical audits targeting older patients with multiple medications. So I know that all the hospitals, we run medication safety campaigns, we have prescription audits. So I know that when I was in the hospital, at least we did not do any specific audits on older, patients, adult patients. We did not do that because those days we did not use this term called polypharmacy. So the support for a greater role of pharmacists in medication management. So throughout the document, this particular statement is being repeated because in many countries, see, when the technical report WHO produces, it is produced based on many research and evidence-based practices done by many countries, all the member countries, and they bring it all together. Then they are releasing these technical reports. The reference itself, half of the document will be references. So it's a very rich document, well researched and well referred. So it is worthwhile to look at what are their recommendation and see what we can do in our own setting. Identification of high risk patients, preparation for targeted medicine management, plans for this group. So once again, when you call somebody high risk or vulnerable, start thinking, is polypharmacy a risk for this group of patient? And to establish a system for blame-free reporting of medication errors. So when we have medication errors, are we looking at the polypharmacy side of it? Did this ADR or the medication error happened because of a combination of things that we discussed about polypharmacy? So now WHO talks about triple aim strategy, and later they changed it to quadruple. So let's look at what are the triple aim that the document talks about. So whatever that we are doing for polypharmacy, the medication safety, it should lead to improved health outcomes. Obviously, the population that we are serving, they should have better health outcomes, and then it should lead to greater patient engagement. So in this particular document, they repeatedly talk about engaging the patient, because the patient is the constant. We discussed about it last time also, and I think engaging a patient is not only good for medication safety, it is good for all kinds of safety. And to improve clinical outcomes, also, we should engage patients more. And it should be cost effective. In the polypharmacy, there are factors to think that, can they afford? I know when I'm managing my parents, medications, I know that how the prescription happens. Some medications are very costly. Not that there is some other brand which is cheaper is not there. There are they have their merits and demerits. We am not getting into that. So when you look after a polypharmacy on a general way, even to the doctors, all these documents are not targeted for nurses specific. I am trying to translate that specifically for nurses. It is targeted for countries and local organizations and the management and the doctors, everyone, students. This is a complete wholesome document. I am trying to interpret into nurses thing. So now the quadruple, the last one they have added is the staff well-being. Now, you might think, what is the purpose? What is the connection between staff well-being and the patient polypharmacy medication safety? I think it has got to do everything, right? If you look at any kind of errors that happens in the organization, the staff's engagement, staff's well-being, staff's commitment to patient safety, everything becomes very important. Because I'll give you just one example. Suppose you are getting the staff to do, let's say, 12 hours of duty for a week. Obviously, you are creating a situation in which the person will be so strapped and tired that they can make mistakes in their decision making, or they can make errors with any procedure that they are, thinking of. So it's very important to focus on the staff well-being, and it's so very heartening to see this being added as the quadruple aim of the entire medication safety in polypharmacy. Now, what are the other factors? The other factors are income, the income of the elderly person, the family support, and the social protection. Now, we are most of the references are from Western countries. We don't have many from the developing countries or the low middle income countries. We don't have many, but I found this not from the document. It is from the net, where they are talking about to what extent people work in old age. So this is just talking about the old age income and security in Bangladesh, Nepal, Philippines, Thailand. So we fall into this category. Obviously, as we age, the income potential keeps, going down. So that's what, but levels of employment decrease with age. And many people keep on working even after the age of 60. People are not literally retiring, see, you can see the percentage, that each country, how much they are saying. But people do typically reduce the number of hours they work as they age. But older women are less likely to be paid doing a paid work than older men. So men tend to work longer. The main reason for lower levels of work is ill health and disability. So now this is a summary of a study done in these countries, and this talk about the same thing, that when we consider polypharmacy, you have to consider what is their income, what is their family support, what is the social determinants of health and lifestyle, where do they stay, and can they manage, can they adhere to the treatment that you are giving. So many times it happens, that let's say look at a chronic renal failure. People will, doctor will definitely advise, okay, you should start dialysis. Many a times maybe they cannot afford, or they are in a place that they can't get the dialysis. So doctor has to think of other alternate methods. Maybe peritoneal dialysis can reach there, not the hemodialysis. So similarly, when we look at the polypharmacy and the prescription or medication reviews being done, this social determinants should be kept in mind. So that is what the document is advising. So now medication related harm in polypharmacy. Now this is all referred. There are many studies which have been done. So I'm just quoting a couple of them. Patients receiving five or more medication had a prescribing or monitoring error rate of 30 percentage. That is one third of the patient. That is a fairly large number of people. If 10 elderly patients are getting medicine, out of that, three of them will have either a prescribing or a monitoring error. While those receiving 10 or more medication, error rate was 47 percentage. Almost half the population, the elderly population, will have some error that is going to happen. And I'm very sure that you know that. Now every time when I was making this, every time I was thinking, how can nurses, contribute to that. It is not that when they are in the hospital, you are going to make a mistake. The fear is when they go home, what is going to happen? How do we know that whether they have made a mistake? And when the patient comes back, they may get readmitted or they come back. Do we even look at it to see that is that something to do with their understanding of the medications, or they have taken some wrong medication, wrong dose? Did they stop something? We are not very sure. So learning from medication incidents is vital. So I was thinking myself that, we do have a quality indicator, readmissions within 72 hours. But do we look at our elderly population who might get readmitted, those who have come and, they didn't come back in 72 hours, but they did come back in another 3 4 days time. But they will not be quality indicator data. So we just have to figure out that, are we looking at that population more closely? Are we paying attention when there is transition of care within the hospital, when they are being sent home, or the people who are in the nursing homes? We don't have that many nursing homes in India. But what non-prescribed medications are being taken? I know that, many elderly population, they will take, some kind of maybe Ayurveda or some homeopathy or some complementary therapy that they will be taking. So do we ask about them when they get admitted in the medication history? If you remember last time we talked about the best possible medication history, BPMH. So when we take medication history, are we taking them? And I added homes here. This was not part of the list in WHO, but I added homes here because in India, most of our elderly are still staying alone at home. So what happens? So we can think on our feet as nurses and as nurse leaders. How can we extend
ആ കൈ
safe?
കൊണ്ട് കഴുകുക, അതൊക്കെ കൈ കൊണ്ട് കഴുകാൻ
Can you please keep yourself muted? So can we extend our monitoring and our advice to homes when we send these elderly patients home? Do we know that when they go home, who is going to look after them? Are they staying alone? Are they, being, supervised by someone to give medication? Or if the children are there, are they supervising the medication or they are taking it themselves? And I know from my own experience, we don't ask all these questions clearly. So I see an opportunity where we can make a difference without waiting for all the other pegs in the entire cycle, the doctors and the pharmacists to fall in line, then nurses will fall in line. I can still see that we can make a difference. Medication review, as we learned last week, is the structured evaluation of patients' medicines with the aim of optimizing the medicine use and improving the health outcome. So, any medication review is not about listing the entire medicines that is there, that is being given for what purpose. So it is also looking at, are there any problems this drug is creating, looking at the lab results, is the liver doing okay, the kidney doing okay, is there any other GI symptoms that is happening. So that is a complete medication review. So it is very important to remember, can nurses also participate, help in the medication review? And I would always say yes, because smart nurses, they can pick up a lot of things that may be amiss in a patient's care and bring it up to the doctor. It is very much possible. Now, this is a nice list which is part of that document, step by step approach, conducting medication centered review. So it's all about, asking what matters to the patient. So I'm not going to go to the fine lines. First, to ask, what matters to the patient and what is the need of this medication. Is it essential? So please understand, this medication review, this list is under polypharmacy. So they say that, all these things should start with first in this category, elderly patients. If you don't want to look at the medication reviews for all patients, start with at least your vulnerable category, 65 years and above, patients who have comorbidities. Can we ask this question? Can we train this to our all healthcare providers? No, this is not essentially falling into the kitty of a nurse. It is definitely falling into the kitty of a resident and the consultant who is looking after that patient. But yes, if we know, we might be able to warn a doctor that, maybe you would like to look at this. Identify essential medications. Is it mandatory for them? For example, they are taking, thyroid medications, or they are taking some medications for dementia or Parkinson's, or they are taking something for heart, they are taking something for blood pressure or diabetes. So all these essential medicines are the ones that they cannot stop without the specialist advice. Now, asking the patient, does the patient take any unnecessary medications? Maybe somebody started something because 2 months ago, maybe the patient had, like we had the case study last month, the patient had some pain, so NSAID AIDs were started, and then it is just continuing. So if you see that after 2 weeks or a month, we should ask the question that, does the patient still need this medication? It is not a mandatory or an essential medication. Is there an indication to continue the same? Is that, does the dose which is written is right? Has the patient's weight changed? Is the medication based on weight? Is the weight being taken? Every time my mother goes for a video checkup, I have to tell the doctor about the weight. And I'm very sure that, he must be considering that when he is looking at all the prescription. Now, the next one is the effectiveness. The medicine that the patient is taking, is it actually doing the work that it is supposed to be doing? So, for example, you have started some pain medication, and when the elderly person comes back, elderly person says, it's hardly made any difference, but somehow I am managing. I still have pain, but the medicine did not make any difference to me. So, do you increase the dose, or you decide that, probably this is not the medicine that needs to be given to this particular patient? So in elderly, you just cannot just simply increase the dose of the medication. So it's very important. That's why the next question, safety. Is this patient at the risk of adverse drug reaction? The drugs which will be quite safe in an younger patient can become dangerous in an elderly patient. So need to look at drug disease interaction or drug drug interaction, robustness of monitoring mechanism. Wherever they are staying, can that be monitored? Now, giving you an example again, starting insulin. Do we really know that at their home is there someone who can give the insulin, someone who can monitor, someone who can monitor the blood sugar? So all these questions needs to be, asked and found out, because there can always be a risk of accidental overdosing. So very categorically, do we tell the patients, because they can forget to take medicine. So it needs to be re-emphasized on them that if they forget to take a medicine, they should not take double the dose with the second medication time, right? Now, last month, last week, sorry, we discussed about teach back. I will reiterate the same thing. So when we are educating our patient, we need to ascertain that does the patient know what to do when they are taking the medications, and what to do in case they fall ill. Do they know the side effects of the medications? Do we tell them that if you feel this way? Maybe we tell a lot of things, but not necessarily they have understood. So that is why teach back mechanism is very, very critical when we are educating our patient. It is important in all categories, but in elderly patient becomes even more important. I have had, situations where, when the parents are sick, the children will come from some city, they'll be with the parents. And at the time of discharge, maybe the daughter or son is there, and you explain everything to the daughter and the son. And then after 2, 3 days, they go back to their city and they leave their parents alone. And probably the parents, they don't know, or maybe something was explained in a hurry burry. So the chances of making a mistake is even more. So it is very important that we should look at the patient as a whole. Patient, their family, where they stay, all these things should be known to us, because in our hospitals, explaining the discharge medications by and large is done by the nurses. Even if the doctor explains, he will not spend that much time. The expectation is from the nurse to educate the patient how to take the medication, what to watch for, and what not to do, what to do, and what not to do. So, patient centeredness, asking, knowing that the patient, do they understand why they have to take the medication? Sometimes there is a possibility maybe the medication that are ordered are very expensive. Maybe one set of medication is already bought by their children, and post that, maybe that medication is not available in the nearby pharmacy. The pharmacist may not help to say that, same salt, another brand is available. You never know what is going to happen. So do they know that if they don't get a medication, they need to let the hospital know that they are not able to get this medication? See, refilling of medications in India is a very, very unstructured way. You just take the, prescription and they just give. And sometimes if they don't have, they may tell, they may not tell. So when you come home, you'll find that one patta is less. And when you ask them, they'll say, oh, we did not have enough medication. So maybe elderly patients may not be even able to understand that this is happening with them. They'll say, okay, I'll get it after 2 days, then I will take the medication. And in those 2 days, anything can happen to that particular patient. So medication changes, can the medication be given in the form that is being, advised? Can the patient take oral medication? Can they measure the liquid medication? Do they know how to do it? If there are injections, how are they going to take it? So finally, to agree what can be done and who will be done and for what purpose this is being done. So it's when I was reading this document, I was just thinking, the more and more responsibility is actually falling on a very conscientious nurse. I use the word conscientious because nurse who really cares, she or he is the one who is going to take all these understanding seriously, that you can bring in safety to our patients. So we already heard about de-prescribing in the video that I have shown in the beginning of the session. So de-prescribing is the process of actually tapering or stopping or discontinuing or withdrawing drugs with the goal of managing polypharmacy to improve the outcomes. Now, this
Shweta?
is something. Hello? Why? Please keep yourself muted. Thank you very much. So the doctor is expected to always consider, does this patient need 8 medication, 10 medication, or some medication? Can that be changed? The dosage needs to be adjusted. So a lot of thought process goes into when they are managing elderly patients. So what are the strategies that can be adopted or implemented, and what can sustain? So the document talks about changing at the national level and at the local level. Irrational use of medication is a global issue that is something that should be understood. So in India also we need to know that we don't have any data, but we should know that if all the other countries have got an issue, we also have issue. Furthermore, half of the patient they fail to take their medicine as prescribed. These are all evidence from different studies. Inappropriate polypharmacy is a common example of irrational use of medicines. So, polypharmacy, by now, all of you are aware what is polypharmacy. So, what can be done? Create effective policies. I'm going to also very quickly talk about, how can that make a difference in a hospital or a, system, Maybe we can ask for better policies to address this with our elderly population. Supportive incentive structure. So they're talking about, countries where they supported the clinicians to go the right way after education, that, they will focus on polypharmacy, they will de-prescribe at the right time. Education and management, educating all the people concerned, and then ensuring the policies that you have put in place are followed, and very important, giving the clinical guidance. Now there is enough guidance available, from various sources. For even the doctors, they can always go and figure out what is the, what are the guidance related to polypharmacy. And last but not the least, is very important to have appropriate training. The document talks about training nursing students, the medical students, the pharmacy students, training everyone about polypharmacy well in advance. So I think patient safety is definitely a domain that everyone is expected to be oriented to. I'm sorry. I just saw this one new word. I'm just bringing it to you just for you to kind of know. It's called a pestle analysis. So this is a nationwide analysis. Obviously, we don't use this model, particularly in our own studies. We don't do that. So this is pestle analysis, and this one will actually go through government policy, economic growth. So it is to be done by, well, experts in that domain. But they also mention SWOT. SWOT is something that many of us are aware of it, that when we want to make a decision, I'm sorry, when you want to make a decision, we look at the strengths. What are the strengths of this particular idea or a decision? What are the weaknesses? What are the opportunities and what are the threats? So I just thought of putting these two tools here as something that you would like to take away with. The document talks about patients and public. So there is a whole lot of focus on actually raising the patient awareness on the problem of polypharmacy and the known adherence. We need to educate our patients, that they have a polypharmacy with them. That means they're taking so many different medications, and the chances of them failing to take all the medications is high. So how can that be prevented, and how can we detect early any inappropriate polypharmacy? And the document insists on making patients and families into shared decision making. Patients and families should be involved. I can see that people are slowly dropping off because probably thinking, it is nothing related to nurses, maybe. And those who are staying back, I hope you are getting the message that as nurses, what can we do? Involving the patients as shared decision makers. All these are part and parcel of even our accreditation standards. But now it is coming into focus, particularly in relation to the medication safety. So patients should be encouraged and supported to disclose all the medications. So if we don't ask them, sir, ma'am, apart from this medication which is written in the paper, what else do you take? Do you take vitamins? Do you take some other supplements? Something that their children have sent from US, that this is very good for bones. Take this also. Unless we ask, they would probably talk about only the medication that they have been given by the doctor who is looking after them. So it is very important to capture all that. And this information must be with the doctors also. I know that it is not our responsibility to educate the doctors, but if we are aware, we can always be an advocate and inform them. Patient tools and materials to support their engagement and to empower them and their families to look after themselves. It's very important. Patient and their caregivers are probably the ones who are going to keep them away from the hospital, safe and sound, but they should know how they have to look after them, correct? So this is another new information which I did not know before. So the document also talks about medicine sick day rules. So those who are here, maybe you would like to make a note of it. What they are saying, this is actually from NHS Scotland, right? So this is a standard, health education that they are giving to all with polypharmacy. So they are saying when you are unwell with any of the following: vomiting, diarrhea, fever, sweats, or shaking, stop the medicine listed overleaf. That means they will tell beforehand, if you have these symptoms, just stop these medicines. Then restart after 24 to 48 hours when you're drinking and eating well. Suppose you are vomiting, you had some GI infection, but you didn't go to your primary doctor, but the patient should know that I can stop the medicine for 24 to 48 hours. And if in doubt, then they are expected to speak to the treating doctor. And this, because it is NHSU, they talk about speaking to the pharmacist, their own pharmacist, GP, or nurse. Now the question is, how many of our nurses are in a position to advise the patients? Do we have nurses who are engaging with the post discharge calls to the patient? I am sure that some of the organizations, they do have nurses who call patients home, asking them how they are doing, are they managing the medications. If you remember, in the last class we talked about health coach, where nurses actually follow the patients as health coach even to their home, to ensure that they are aware of these 5 moments of medication safety. Now, these are the kind of tools which are available out there, which any one of the hospital, any one of you can look at it and initiate. Now, prioritizing patients for medication reviews in polypharmacy, where the document, WHO document, talks about prioritizing patients in care home settings, patients who are on high risk and high alert medication, those who are taking 10 or more medicines. Please remember, this 10 number is including all kinds of medicine, supplements, complementary drugs, everything. Patient has 2 or more comorbidities that we already discussed. Patients who are very frail, patients with dementia, palliative care. These are the domains that they're saying. In this, there's no other way. You have to prioritize doing a medication review so that the appropriate drug in the right dose is being prescribed for them. And how about healthcare professionals? What does the document talk about healthcare professionals? Raising awareness, that's the most important. And we at Signia Healthcare is trying to do that by raising awareness. We are trying to take time to read the document, make it simpler, and share with all of you. Education in medication, nursing, and pharmacy schools. So include that in the curricula. We already know the WHO patient safety curriculum is already recommended, and many countries have adopted that into the medical schools. And in India also, in the nursing curriculum, the patient safety has been already included. So the recommendation is also to deal with all the medication safety, at least the three major aspects, that is the high alert, high risk medications, transitions of care, and polypharmacy. And to have a patient centered medication review. That means don't just ask what all medicines patient is taking, for what purpose, when was the medicine started, is there any drug interaction, is there any drug diagnosis interaction, any drug food interactions. So this review should be done very intelligently for that particular patient. That's why a multidisciplinary team approach is being recommended. That means the physician, nurse, and the pharmacist must be included in managing the polypharmacy. And keeping in mind the knowledge of human factors. Now, human factors is something that you can read extensively in the WHO patient safety curriculum.
I'm not able to hear you, ma'am, actually.
Ma'am, not able to hear.
Sorry for the inconvenience. I think she got disconnected. I will contact her.
Thanks.
I'm sorry, friends, I had a network issue, so I just got logged out. I'm back. We have few more slides to cover, and then we'll try to wrap it up very quickly. So, where were we? Okay, so we talked about prioritizing high risk and high alert medication when patients are taking, when they are taking more than 10, pay attention. Maybe this is a checklist somebody can create in the hospital also to figure out who are the patients who are at higher risk for, medication harm from polypharmacy, patients who are frail, patients with dementia. I think we finished that, palliative care. So healthcare professionals, I think this also we almost finished, and multidisciplinary and knowledge about human factors. And the last but not the least is to choose evidence-based care. Now, when it comes to polypharmacy, this document itself has enough and more references, where you can find all the evidences that is required for you to answer the right question. Now, this is a very interesting reference, so I just brought it here. Choosing wisely. This is a campaign that has been done in all the advanced countries. So you can always look at this website, Choosing Wisely, and that particular domain will tell you how to teach the patients and the physicians to advise wisely. That means to ask that does the patient really need this test or procedure? Does the patient need this medication? What are the risks and what are the side effects? Are there simpler medications, safer ones that can? I'm just translating the procedures and tests into medication. And then what happens if nothing is given? What happens if the test is not done? And how much does it cost? And can I afford it? These are the questions even the prescriber or the doctor should be asking along with the patient. Can you afford to do that? Many times, in India, we are not so aware that we have to ask these things, and patients also don't ask. I think there's a whole lot of patient and public education that needs to be done for understanding that, so you can see a Society of Critical Care Medicine, they came up with this, choosing wisely. So telling the patients and the doctors that don't retain catheters and drains in place. We know that that is related to hospital acquired infection. Don't delay progress towards liberation from mechanical ventilation, prevention from WAP. Don't continue antibiotic therapy without evidence of need, antibiotic resistance. Don't delay mobilizing patients, your VTE problems. Don't provide care that is discordant with the patient's goals and values. So this is where the medication part. So many entities, many associations have come up with this, choosing wisely statements. So when you actually Google, you will find whole lot of things there. So even for medicine, choosing wisely is a campaign that many countries have done. When it comes to medicine itself, know about drug interactions. There should be a database that one can refer, but the document insist more than the database. The people who are prescribing the medicine should use clinical judgment. And for nurses also, this is very important because we get a lot of test results, we get a lot of numbers, we get vital signs. Every time we say no, we have to use our clinical judgment to make a decision as to what this particular number means to this particular patient, right? So that's our critical thinking. Adherence to medicines to ensure that the patient is able to take the medicines. Do they need any aid to memory or pill box? How do we help? So my mother pretty much she takes her own medicine, but I have given two different boxes labeled as morning and night. So all the morning medications are kept in that one box, the other one is there, and then she kind of identifies the medicine by the look and feel of it. She does not read it, but now and then I go and check, tell me what are the medicines and what are they for. Then she will tell me, this is for my blood pressure, this is for my diabetes, and this is my multivitamin, this is my calcium. To do that, but we may have to facilitate that. Is there reminders that needs to be sent? Who is going to monitor that? Can we look at digital health tools? WHO is definitely going to work on that. And as I told you about the 5 moments of medication safety, there is an app available for patients. I thought it was for nurses, but it's not. You can always look for that app, and maybe patients who have kind of they are tech savvy, you can actually advise them to use that as a reminder and to check for things. They'll have everything in their mobile application. Large print labels and info sheets. Now as I am 63 now, I am not able to read the very small labels on the medication boxes or on the labels. I'm finding it difficult. So I do have a small magnifying glass. If I really have to read myself, I will do that. But I keep thinking about, all those patients who might have a challenge. So do we give them what they need to know in a format in which that they can read and remember? So what can be done? We can improve our systems. We can ensure the change happens in our practice and in education. Always have a multidisciplinary approach. Monitor. Monitor and measure is something that WHO document is talking about evaluating. So they have come up with this one indicator they're calling total number of patients on polypharmacy. So inclusion criteria, all patients with 10 or more regular medicines, or patients receiving between 4 and 9 regular medicines who also are having other kind of medicines, divided by total number of eligible patients in the target group. So if you're taking all patients who are admitted who are above 65 years of age, and you have to apply this criteria and find out what is the prevalence of polypharmacy. So you will come to know maybe percentage of your target population is on polypharmacy. These are very interesting data one can gather if you are interested to play a role in ensuring the safety of polypharmacy in our patients. We come back to role of nurses. I go back to basic again. Know what you don't know, ask and check multiple times. So immediately when I think of what can nurses do, I just think, there are areas that nurses can immediately start to work. Identifying the vulnerable patients and, tracking that they also on high risk. How many of them are taking so many medications, 10, more than 5? How many have comorbidities? The patient safety nurse or the nurses, can they be trained to identify these patients and knowing that they can be harmed by the medication that is being prescribed? Can we take responsibility to raise awareness in our patients? Can we start educating them? Academicians, can we introduce this topic of medication safety for our students? Can we involve nurses to take a complete, basic, proper history? And when they develop the nursing care plan, can they remind the doctors and other caregivers, our patient is at higher risk? Can we educate ourselves on human factors? Most importantly, the basic, I would say the basic. When patients go home, can we educate them in a language that they can understand and always use a teach back methodology? Right now, tomorrow itself, you can start the new method. You don't need any protocol, you don't need any Indian guidelines, you don't need any doctor to tell you. So many things that we discussed in the last 2, 3 weeks have been around what nurses as individuals we can do. And that is where we can start, right? Know, check, and ask. So I know that polypharmacy was maybe sounding like a dry topic, but let me tell you, you will know that out of your assigned patients, what is the percentage of this high risk group with you. Then you can appreciate that how much of risk that you are taking when you are giving medications to these patients. This is very, very important to keep in mind. So that is the end of today's topic, and next week is our last session, and that last session is on safe medication practices for nurses. So we are going to put together uh, a 60 to 90 minute session where we'll summarize every nurse, every individual nurse. We are not going to talk about the processes and systems, every individual nurse, what can she or he do to ensure that personally they take the accountability to be a safe medication nurse. All the nurses out there at the bedside are administering medications. But are you thinking that such a big responsibility you are carrying on your head? Am I having all that tips that is required to be always adhering to safe medication practices? What are the challenges? And if I face those challenges, what can I do? And that is what is going to be discussed by Lindsay Jeswin next week. And that will be going to be the closure of all that we discussed, whether it is transition of care or it is, highlight medications or it is, polypharmacy. We're going to put it all together and say, as nurses, starting tomorrow, what can you do to make sure that you are as safe as possible to our patients? With that last note, thank you everyone. Thank you very much. And I will stop the recording now. And then if there are any discussions from any one of you, I would like to hear that. So thank you so much. Stay safe and stay positive, and let's be safe for our patients as well.